Hi there, everybody, and welcome back to Just Ask Dr. Macie and Guests. I'm your host. I'm Dr. Macie Smith, the social gerontologist providing education, training, and caregiver coaching to help you and your families reach the next best level of care. So for many of you, aphasia is a term you've never even heard before. You just started learning about the term after the diagnosis of actor Bruce Willis and how it's affected his life. Well, there's been some conversation about whether aphasia is even a diagnosis or is it a symptom. So by now, you know me, and you know that I'm not going to attempt to break any of this stuff down, I'm going to try to break some of it down, but not all of it. I'm going to bring in the experts who live and breathe this world to help us address what aphasia actually is. So today, guys, let's welcome to the platform Rene Mills and Katie Zenger. Hey, ladies.
Good morning.
So
hey, y'all.
At my top left, my left, and maybe you're right, we have Miss Rene Mills. Renee is a speech pathologist specializing in the treatment of acquired brain injury for over 30 years. She is a certified brain injury specialist trainer. She was also honored in 2017 by the Texas Brain Injury Alliance for professional contribution for dedication and service and advocacy to the brain injury community. Welcome, Renee.
Thank you. My pleasure to be here, Dr. Macie. I'm looking forward to our conversation about aphasia.
I am as well. And in my bottom middle, she's no stranger to the platform. That's Miss Katie Zenger. She is a returning guest. She brings the knowledge. She has the master's in public health. She's also an ambassador for the South Carolina Association for Frontotemporal Disorders. And I know you're saying, well, Macie, you said that we were going to talk about aphasia today. Well, we are, but we're going to start with FTD, Katie. Can you tell us the connection between aphasia and FTD? And is there a connection?
Absolutely. So I'm happy to do this. So I'm going to do a quick little correction because we know we like to get all our names right.
Yes,
so
we do.
I am the South Carolina ambassador for the Association of Frontotemporal Degeneration, which is an umbrella term that frontotemporal degeneration is an umbrella term for a lot of different neurodegenerative disorders that happen in the brain. And so FTD is the disorder, which is frontotemporal dementia. There's a lot of other names for it, but that's what we call it. FTD is the dementia, frontotemporal dementia. And then AFTD is the association that I work with. And so I'm the South Carolina ambassador for them. So thank you for this opportunity. I'm really excited to be able to talk about this because it's so misunderstood and not enough is known about aphasia in general, and then not enough is known about these rare dementias that actually can cause aphasia, and that's one of the symptoms. So there's two main types. So under the FTD umbrella of frontotemporal degeneration, and that's frontal temporal parts of your brain, there are two main types. One is the one I talked about last time on your show, which we had a great time, called behavioral variant frontotemporal dementia. And then the other variant or subtype is called PPA, or primary progressive aphasia. And that's usually when the left side, and we're going to let Renee talk about this piece because I am not the major expert in that part, but that is when your mostly temporal lobes and these language centers of your brain are atrophying, or that brain matter is shrinking, right? So last time we talked about the frontal lobe shrinking and what effects that has. And now the aphasia part is where we talk about where the language centers are atrophying or shrinking. And so then it affects our language, and that's the aphasia piece. Renee, is that an okay layman's
You
definition?
hit the nail on the head, Katie. That was beautiful.
Didn't she though? So Katie, I'm glad that you made that connection. When you talked about aphasia, you talked about language and you talked about communication. And that's kind of where Renee comes in and why I stalked her a little bit with speech pathology. I think speech pathologists are like the creams of the crop. And I got to give a shout out to my university, South Carolina State University, Renee. Renee, you're on the West Coast, we're on the East Coast, but in Orangeburg, South Carolina State University, which is the state's only 4-year state-supported HBCU, historically Black colleges and universities, we have an award-winning long-standing speech pathology program. Before we get into that association between aphasia and speech path, what is speech pathology and how long have you been doing it?
Well, when I tell you how long I've been doing it, you'll know how old I am. I've been doing it for 30 years. And I have to tell you, Dr. Macie, my first job was actually in Florence, South Carolina. So I was in your neck of the woods.
Yes.
And I can't recall the name of the dean over in the speech pathology department, but I knew her at the time, and they have a fabulous program. So I was there for a couple of years, and my very first job as a green speech pathologist.
Yay! Connections.
That's right. That's right. So a speech language pathologist or a speech therapist, as we're more commonly known, it's the same thing. It's a 6-year degree. So you get your undergraduate in, you can get it in special education, the educational field, and make up prerequisites, but then you need to get your master's in communication disorders. Then you do a 9-month fellowship called a CFY or clinical fellowship year, where a supervisor has to sign off on all of your reports, all of your notes. And then after that, you are free to fly and you get your C's. And I tell people that's the only time in your life you want C's. You always want A's, right? But you want your C's when you finish your clinical fellowship year, and then you're able to practice on your own.
Wonderful. Thank you for explaining that, because a lot of people, I think they get confused in terms of what a speech pathologist actually is. And I'm glad that you made that connection. So what is that correlation between speech, communication, and aphasia?
Well, we're primarily the professionals that deal with aphasia. Some neuropsychologists also do, some cognitive specialists do, but we're primarily the ones in the hospitals, in the acute rehab units, or even in home health services that will be the ones directly responsible for evaluating and treating aphasia. So we're seen as the primary I guess the primary treaters of this, and also the primary disseminators of information about aphasia, how to work with it, what does it look like, and what's the prognosis.
So I'll say this now, there's been some conversation, of course, around the diagnosis of Bruce Willis, and Renee and Katie, y'all can jump in here. We'll have a convo about it. Is aphasia a diagnosis? Is aphasia a symptom of a diagnosis? Because it does affect part of the brain where speech happens. So, there's a part of the brain that manages speech and language. And then there's another part of the brain, which is in the frontal temporal lobe, that manages understanding of the language that's spoken. So is aphasia a diagnosis, or is it a symptom of a diagnosis? I know it's a frontal temporal disorder. I'm so scared to say the wrong word over here, Renee.
So I actually think that's a Renee question, because I don't diagnose or treat anything. I am just, I'm here as like a health educator and an ambassador. So my understanding is that it's a symptom or something that happens when you have a stroke. It's a symptom that you can manage. But in the case of primary progressive aphasia, it's, yeah, you know what? I can't do it. Renee, you're gonna have to do it.
Come on, Renee. Look, Katie said that's all I got. Come on,
no, Katie,
Renee.
you did great, Katie. Here's what I would say. I would say it's both. And the reason why I would say it's both is it is a disorder itself. It's a language disorder. So in that sense, Katie, you can say aphasia is a disorder. It is a disorder of language or impairment of language, and it can affect any of the 4 modalities. So the 4 modalities of communication are reading, writing, speaking, and listening, right? So in that sense, we can think of aphasia as a disorder. However, we can also think of it as a symptom that there has been damage to the brain, and it could be of many different causes, the number one cause being stroke, right? So in the case of Bruce Willis, my concern, or my spidey sense went off when all of a sudden we get this diagnosis. He has aphasia, and it's everywhere. And people are thinking, well, what is this? 1 million people are diagnosed with aphasia in the US. And there was a survey recently done that indicated only about 86% of the population had no idea what it was.
I believe it.
You know, a good opportunity for us to do what we're doing today and inform the public about what it is. The fact that Bruce Willis did not have any big announcement, or his publicist didn't say he'd been hospitalized, he's had a medical emergency, he's had a stroke, it raised my spidey sense for something that was more slow, more insidious, and more progressive. And that's why I instantly jumped to what Katie's very familiar with, primary progressive aphasia.
Right.
Why is it called PPA, Katie? Primary progressive aphasia. You know, I like how Renee took us back to school. Now, I'm not old school, but I am middle school. The 4 modalities of communication, right? Reading, writing, speaking, and listening. Thank you for that rudimentary lesson, because we do need that. But why PPA, primary progressive aphasia? Is it something that gets progressively worse in terms of, is there a typical path or typical symptoms that occur early, middle to late, or is it just kind of everywhere?
Ooh. So
with
primary progressive aphasia, Renee, if you want me to take, so this is like, we're being happy and like loving on each other because this is our wheelhouse, and we really want to get this information out here. But this is a very serious and absolutely devastating set of diseases, these frontotemporal disorders. And so when you have the PPA variant, that primary progressive aphasia, it means that your brain is shrinking. This is not the person trying to make it difficult to communicate with them. You know, it's that they cannot get the word out, or that they cannot remember what the word is for common objects. And so what you see with PPA, as you see with many of the frontotemporal disorders, is that it comes on earlier than you would expect a dementia to come on. Right? And again, this is why, and it is progressive. Yes, there is no cure and there is no treatment. There is only management of symptoms. And so that's what we have to remember. With a stroke or with a traumatic brain injury of some kind, you can go to a speech pathologist like Renee and you can get better, right? Your brain can still remember how to read, write, communicate, like speak and listen. Unfortunately, with PPA, when you have primary progressive aphasia, it's your neurons are degenerating. They are literally just, they don't exist anymore. And so you have to understand that there's no speech therapy that you can do to bring your person back with aphasia or primary progressive aphasia specifically, but there are things that you can do to be a better communicator with that person who has PPA, right? And so it becomes on the caretaker, and that's why I'm glad we're speaking to your network, Macie, because it really gets put on that person who's giving the care to do the best job to help them communicate. And so I'd love to talk about those pieces later too.
That's right. Renee, what are some of those compensatory strategies when it comes to progressive primary aphasia? As Katie stated, there is no cure, there is no treatment. But before we get to that, in terms of the compensatory strategies, Renee, as we're talking about it, it's very reminiscent of dementia, because there are over 100 types or 100 causes of dementia. Some people are diagnosed with dementia, but we all know that that is a symptom of something else, of an actual diagnosis. But we know that something brings dementia on. Does something bring on PPA? Or is that one of those things that we still just don't know?
Yeah, that's a good Katie question. I would say that we don't know PPA versus other types. What causes them? We know it's some irregular proteins in the brain. I loved how Katie talked about the progressive nature, and that's the piece that I think is important for people to understand. If you have, let's say, an ischemic stroke, and there are 2 types of strokes, ischemic and hemorrhagic. And if you have, the ischemic stroke is a smaller area of the brain where the tissue is deprived of oxygen and it dies. In contrast to PPA, which is a larger region, and it is just the degeneration of those nerve cells or neurons and their connections to each other. So with a stroke, it's very focal. The damage is focal and it is not continuing. That damage happens at the time and it stops. And so that's a huge difference between PPA and a stroke. You can have recovery because you're not having that continued death of the neurons and their connections to each other. So with PPA, one of the things that is notable is that it's very slow.
Yeah.
And I think to the folks that are listening, it's important for them to know, you need to go get assessed. You need to get a brain scan. You need to be seen possibly by a neuropsychologist or speech language pathologist for testing. So I'm going around your question a little bit because I want to really focus on for a moment that initial year when family members, loved ones are seeing, oh, wow, they stumbled on a word, they couldn't call up a word. And of course, your mind goes to the worst, right?
Yeah.
They do have dementia. Sometimes there can be tiny TIAs, transient ischemic attacks that happen. They can be treated. However, if you have too many, if you have repeated ones, that also can eventually lead to a PPA. So I don't want to be confusing, but they are so different, and I just wanted listeners to be aware that when they first see that or feel like something's not right in the way this person's communicating, it's always best to get an assessment first.
I totally want to, reinforce that. That's also what the AFTD recommends. They have some great resources on their website. So there's the doctor says it's FTD, now what? And that talks about both behavioral variants and PPA, what you should be doing. And it is this assessment so Macie, you picked like one of the most complicated brain situations that you can have right now, because the question you asked about what causes PPA or where does it come from? Well, one, we don't know. Two, unlike behavioral variant FTD, PPA seems to be much more what they call sporadic. It does not have a genetic component like behavioral variant FTD does. And so it can come out of nowhere, and they have no what pre-existing risk factors that they can find that are causal for PPA. So it is one of those very unfortunate scenarios where we just do not know why this happens, but we do know how it happens and how it affects the brain. So I feel like we have to focus on what we do know and how we can better treat and take care of folks that end up with these disorders.
I think you're spot on. If we don't know what causes it, we know what it looks like. We know what those signs and symptoms are. What are some of the early signs and symptoms? And I just, again, it's reminiscent of dementia. And what we would tend to do is go straight to dementia. And what happens is we don't get the diagnosis that's an appropriate diagnosis, which means we won't get the proper treatment. We won't get the proper care. And I often tell my caregivers, stop being the doctor. You didn't get your degree as a medical doctor. Don't go in there telling the doctor what you think your mom, your dad, or your loved one has, because you just saved that doctor 3 minutes of the 5 minutes he or she spends with you or with your loved one. Allow them to do testing. But here again, if they know more, then they know what to make recommendations about or what to ask the doctor to look for or to what to consider, because doctors do depend a lot on family members and family caregivers because they know their loved one way better than any doctor does.
Dr. Macie, that is huge. So I think in particular with the FTD disorders, with primary progressive aphasia and with behavioral variant FTD, the family member does need to help the clinicians with the diagnosis, because only you as the loved one know their previous behavior and their previous abilities versus what's there now. So you are, as a family member or a caregiver who has known this person, a very critical part of having a clinician understand what's happening. However, you're right, WebMD is not an MD. So
not at all.
There's a balance there, right? But you asked about first signs and symptoms, and some of the first signs when it comes to primary progressive aphasia is that is the word recall, but not for like, I forget what the thingy-mabobber is called all the time. You know, like it's not the same stuff of when you're stressed or in a hurry. It's like you're at the dinner table, everything, you're having a nice dinner, and someone says, please pass me the salt. And someone's like, and they would say, well, what is salt? Like, what do you mean by that?
So
Or
the understanding of the word that you hear.
right. The understanding of the word that you hear, that's critical. So those common words and people that you've known for a long time having extreme difficulty recalling those words up, those are some of the earliest signs of PPA. You can also have, with primary progressive aphasia, some commingling of the different symptoms of these like weird behavioral variants. So like we talked about in the last session, in our last conversation, my dad started just acting strange, acting crazy. And that can be some of the first signs of behavioral variant FTD, but you can see some of those funny behaviors or not normal for that person behavior. Right. In addition to language issues, you absolutely need to go get some sort of baseline, some sort of, not diagnosis, but some sort of testing to understand where that person is with their speech and language abilities.
Absolutely, establishing that baseline. Yeah. Renee?
Well, Katie, I like what you just said, because there is a behavioral component. We're talking about the frontal lobes. So Dr. Macie, if you don't mind, I'm going to speak to the frontal lobes just a minute, because I work with frontal lobe syndrome in acquired brain injury. That's my specialty. And we're always dealing with behaviors that arise from damage to the frontal lobes. So what Katie is speaking about, that bizarre behavior, is due to the frontal lobe, particularly the prefrontal cortex and the medial dorsal portion of the frontal cortex, not having damage and not connecting with other areas in the brain. We can see things like disinhibition. Someone may disrobe when they shouldn't. They may go walk out in the street naked to pick up the paper and not think anything about it. So we say, well, their filter's not working. That's one of the phrases you'll hear, the filter's not working. Well, they're not inhibiting these thoughts or actions that you and I might normally throughout the day. So that's one sign. Another is anger, and both the temporal lobe, the anterior part of the temporal lobe, and the frontal lobe together are, and in the limbic system, are responsible for our aggression, for our anger. And sometimes you can see explosive anger in somebody during a situation like at the dinner table. You know, anytime you see that kind of quick explosive anger or very bizarre behaviors, putting something in the refrigerator that doesn't belong there, you know, the organizational piece, the thought organization, and what I call scripting. You know, we have scripts in our lives. And by scripts, I mean, when you go to a restaurant, you know, you've been there before, you know, I'm going to be seated, I'm going to get a menu, I'm going to decide what I want, the waiter or waitress will take my order. By script, that's what I mean. There's these roles. We know what's going to happen because we've been there before.
Routine, remote memory.
You've got it. You've got it. And someone with frontotemporal problems, whether it's a PPA or it's due to a head injury, they will lose that script. They will lose, and we tend to think of it as an organizational or sequencing skill, but they've lost that script. And so that's part of the issue. So
you know, this is such an intriguing and multi-layered and an in-depth conversation to have about PPA. Not only are we talking about PPA, primary progressive aphasia, but we're talking about frontotemporal disorders. We're talking about brain injury. We're talking about dementia. No matter what area we're focusing on, it is a neurocognitive condition. And so when you look and you see these changes, what I like to call these responses that have no triggers, these responses that are unlike the person, because I'm very big on not comparing people, not comparing cases. I can't compare my dad to your dad, Katie, or to your mom, Renee, because they're all individual people. They all have individualized experiences. And so when the family member actually determines that there is a concern and they have to go to the doctor, it's very vital that they speak to accurate information in terms of helping the doctor or the physician to establish baseline. What were they able to do before, or what were they not able to do before, and what has changed, right? So there's really no 100% way or conclusive way to say on the first visit that this person has PPA, which was you all's concern when we got the report. And I say we because everybody got the report that Bruce Willis had aphasia, PPA, and not only that he has it, but that he's retiring from acting. So PPA can most certainly affect your career because it affects the way in which you connect with the world around you, which is the way we communicate and how we communicate. What are some of the compensatory strategies would each of you share for caregivers, for family members, and for loved ones? We can start with you, Renee.
Okay.
And then Katie.
Okay. Well, since it is of a progressive nature, we're not going to engage them in the usual restorative type of therapy activities that we would do with a stroke survivor who's had an ischemic or hemorrhagic stroke. What we're going to do is try to maintain as much as possible some level of functional communication. So that may mean that we develop a picture routine. That may mean that we label things in the house. If there are medications, of course, they're going to need assistance taking them, but we may put lots of labels. If their vision is fairly intact and simple words, single words are easy to read, we may label those. Later on in the discussion, I've got some resources I would like to share that are apps. Some are free and some you pay for, but there are some apps now, and that's the wonderful part of our technology, is that even on a regular phone, we can utilize now apps to help speak for us. And there's certain things we can do on the computer with reading that I think are really helpful. For example, if someone likes reading the newspaper and they're having trouble with the actual reading. So there are a lot of little shortcuts, but I would say the realm of it is truly totally compensatory and not of a restorative nature. And we're just, the caregivers need to be prepared that we're going to have to step down the level of abstraction and get to more very concrete types of things, such as pictures or maybe single words on paper.
Very important, concreteness. Katie?
So the things that I just learned, and then also being a caretaker for my father, he did not have PPA exactly, but he did have a hard time understanding and processing information because his brain was shrinking. So some of the same strategies for like setting your loved one up for success to communicate and maintaining their sense of dignity and respect for a long time, for me, that is the priority, or it feels like that's the right thing to do for folks, because even though they can't recall the words correctly or their language is not, what it used to be, they still understand, especially in these first few years with primary progressive aphasia. There's still so much understanding that's happening. They just can't communicate it back to you. And so maintaining two critical things that I heard actually just last week at the AFTD education conference were, one, do not speak for the person unless they have asked you to do so. So that's a big autonomy piece,
That's
right?
huge.
Like, they're still here, they're in the room. You have to be patient and give them enough time to respond if they want to respond. And then you can ask, do you want me to finish that sentence for you? Would you like me to help you communicate this to another person? And then if they nod or indicate a yes or a no to you in another way, then you can do that for them. But don't assume that they want you to finish that sentence. So I think that's one of the biggest ones in maintaining dignity and respect and setting them up for success and failure, or setting them up for success is making sure you're not speaking for anybody.
I love that. I think it's huge. And you know what it reminded me of for people who, and I hope I'm using the right word, who stutter.
Oh, sure. Yeah.
Very, very, very similar. And I like to associate newfound information or newfound diagnoses and conditions with something that's familiar, even though it's not the same. A lot of the strategies and engagement tools that we use are very similar, and people are able to grasp those a lot quicker. And if they're able to grasp those concepts, they'll be more apt to put them in play, and that will ultimately benefit the person who's living with the condition. Well, ladies, thank y'all so much. This has been a joyous conversation. And for some reason, Katie, I told you this last year. I said, I think we're going to have you back. We're going to have a part 2. So I think we're going to have a part 2A, right?
Yeah.
We got to bring Renee in on this, because I do feel that it allows people to not only recognize that their loved one may have some concerns that may require looking into, but it gives people an opportunity to establish those concerns early on. Katie,
Yes.
you mentioned earlier too that PPA, you didn't say it, but this is what I'm thinking when you said it, would be considered early onset when we talk about brain deterioration. And I'm thinking about dementia and Alzheimer's disease, how early onset, which is going to lead me to a question, and you may not be able to answer this question, and I'm okay with that, because I always got to ask a zinger, no pun intended, Katie. Early stages, so early stages of a progressive type of dementia or Alzheimer's disease, it tends to run its course or progress a lot faster, and so that person would pass away earlier than someone who was diagnosed with a progressive type of dementia after the age of 65. Can PPA kill you?
Yes. Yes. So what happens in the longer term? Sorry, it's a simple answer, Renee. I don't want to be over, yes, because what will happen is because it's language, it's your brain, and the words can't always come out. But what'll end up happening as it progresses is that your lips and tongue and throat and all of these muscles in here are connected with your ability to speak. So as your brain deteriorates and your speech goes, so does a part of it is your ability to like move your tongue and your mouth around your teeth. And so that also then means, and then Renee, you're going to have to remind me of the term, but it means you have difficulty swallowing.
Dysphagia.
So you end
Look,
up with,
Katie, I can answer that one, but I say it
one?
fancy. Look, I say it fancy. I say dysphagia.
Dysphagia. So like that, you can choke, and then you can have difficulty getting food into your system, and then they won't want to eat or won't be able to drink because it's painful and they don't know how. So you can absolutely pass away from this through those kinds of issues. Renee, is there anything else I missed with that?
No, you two ladies did terrific. I'm impressed. It makes me feel great to hear that.
So bring that on home, Renee, because dysphagia, and I'm glad you mentioned this, Katie. Dysphagia is huge when it comes to individuals who are experiencing cognitive loss. And a lot of people don't even really understand how someone dies from Alzheimer's disease, right? Because it's still really understanding what the disease is. And when you're talking about PPA or aphasia, and we're talking about language, people don't make that connection that it could cause death. So if you could speak to a dysphagia for a little bit, Renee, that would be great.
And you're meaning dysphagia, the swallowing disorder.
Yeah,
correct?
And I was going to say that. Thank you for breaking it down. The swallowing, is it another type of dysphagia?
Well, people will pronounce aphasia sometimes as dysphagia, and that's another term, though we typically use aphasia more commonly.
Okay.
And so sometimes I've seen in medical reports when someone's dictating, they'll transpose the word. So that's why, yeah. So it is very important that that we know which one we're talking about. I'll read doctors' reports that say dysphagia with an S, meaning a form of aphasia.
Oh my God.
Not severe. Yeah, so I don't want to get in the weeds. Yeah.
Good. So we're talking about dysphagia, the swallowing disorder.
Yeah. Well, and interestingly enough, and I'll speak overall in a general sense, Dr. Macie, if that's okay. In a general sense, when the brain is degenerating and it's shutting down to more of the core cortical functions, it's not so much that they physically can't swallow at first. It's more that the drive is gone. The drive to say the thirst drive, the hunger drive, all of those, quite a few of those are in our limbic system, and the limbic system is right under the frontal lobe. So we lose that drive. My grandmother had dementia, and my aunt actually had frontotemporal dementia, though I observed it from a distance because she didn't live in our same town. But they lose the drive, and that's where 20 years ago, everybody would instantly pop in a G-tube. Because they're not eating, they're not drinking.
No, exactly.
That was the answer. And
That's
now
right.
I'm thinking, if I get dementia and somebody puts a G tube in me, I'm going to come back and haunt you after I die.
That's right. Katie, you know, we talked about that a little bit. Thank you, Renee. Thank you for
Thank
bringing that
you.
home. But you
Yes.
know that, and that's old school too, because a lot of older people and people who are not new school in the industry, if they're not eating and drinking, you're supposed to make them eat or drink. But no, Renee said, absolutely not. And I say it too. And Katie said it. No, if they don't want to eat or drink, they have the right to not want to eat and drink. Go ahead, Renee. Sorry.
Well, I've come around, and in my 30 years as a therapist, when I watched that, I thought, yeah, this is the thing we do. And over the course of our medical advancements and our advancements of our knowledge, I believe that the dementing process is one that should be allowed to run its course. They're not going to feel hunger. They're not going to feel thirst. It's not the same thing as neglecting them, but it's letting them die with dignity. And I know it's a whole nother topic, but I feel strongly about that, in my 30 years of watching, observing, and working with patients.
Yeah.
Keeping them comfortable and letting them maintain that dignity, I think, is something that, like, if you're in this field and you're watching it and you're a caretaker, you can see how important that is, but that the medical community is not quite on the same page. It's really interesting.
Well, there's a guilt that gets instilled. There's a guilt that you're neglecting them. Neglect gets used a lot. And there's this feeling that you're not doing everything you could for your loved one. And here's what I'll say. When my grandmother passed, it wasn't because of eating. She developed decubitus ulcers on her hips. And to me, that was a rougher type of death. She developed sepsis because of those wounds. And, in retrospect, if I could teleport back 30 years, I would have really talked with my family, and we would have all talked more about, let's not put in the feeding tube. And that's another whole topic you can get into. What about it when family members disagree on end of life issues? So
yeah.
I know that's not the scope of this conversation, but as a speech pathologist, that's something we deal with quite a bit. So
yeah, that's chapters, what, like 5 through 10, Dr. Macie?
It is. And I think it's a topic of discussion that we'll need to have on this platform. Absolutely. Especially since the pandemic. The pandemic has certainly shined a spotlight on a lot of conversations that should have been had years ago. But we use these opportunities to really encourage and bless our families. And that's why advanced care directives need to be in place before they need to be in place. So ladies, as we close out this very intriguing conversation, we're going to start with you, Katie. I want you to leave our community, because it's our community. Once you come on as a guest, you belong to the Doc Squad. So I want you to leave the Doc Squad with some resources, accessible resources that they ain't got to search for, right? And I'm going to drop the links in the comment section below so they can just click on it and get what it is that they need, or something that can lead them to the right direction.
So the AFTD has a wealth of resources, and there's stuff that's very specific to PPA and how to manage that. There are also specific support groups for caregivers managing PPA in your state. And so you can go to www.theaftd.org. And there, it's right on the page. You can look for PPA right on the page. You can find those things, and I'm happy to provide links. You can also always email me if you need support or access to those things at kzenger@theaftd.org. And I can help you get whatever you need. And that's my job as an ambassador. So thank you for having me on here and helping us raise awareness, Dr. Macie.
Thank you for being here, and thank you for those resources. Renee?
I have a couple for you, and these are related primarily to aphasia in general. One is the American Stroke Association. It's part of the American Heart Association, and they have a newsletter, an e-newsletter called Stroke Connection, that's filled with excellent stories of caregivers and survivors. I would also recommend the American Stroke Foundation, which has quite a bit of information and resources in the library. They also have materials in Spanish. And then finally, abilitynet.org.uk. So this is a British platform, has a lot of apps, and they'll tell you whether they're free, you have to pay for, whether they're iOS compatible. It's a wealth of information. So those would be my top three.
Thank you, ladies, so much. We really appreciate your time, your resources, your talent, your information. And I know that our listeners and viewers will take heed to some of the recommendations that you provided. And we really appreciate you. And thank you for stopping by. And I feel like we're going to see you again.
I hope so. It's been a pleasure.
Yes. Thank you. So until next time, we'll see y'all later.